Good evening, everyone. Welcome to another session of the continuing educational webinar series conducted by Vijaya Diagnostic Center. Thank you for joining us for today's webinar. I am Dr. Geeta Jahagirdar, lab in charge of Vijaya Diagnostic Center at HOWELL-JOLLY. Today, we are presenting red cell morphology, which will be presented by Dr. Lakshmi Gayatri, who is our consultant pathologist. As for our presenter today, Dr. Lakshmi Gayatri is a consultant pathologist at Vijaya Diagnostic Center of HOWELL-JOLLY branch. She has completed her MD from JNMC Belgaum. She is with us for past 6 months and is a very promising and energetic pathologist. Now for our viewers here, if you have any questions during the presentation, please type them into the question box in your control panel. I'll bring them up after the presentation is over during the question and answer session. Without much ado, I would like to hand over the time to Dr. Lakshmi Gayatri.
Thank you, ma'am. Ma'am, is the screen visible?
Yes.
Very hot good afternoon to one and all. Today's webinar topic is red cell morphology. Though it is a basic topic, it gives us very important clue for evaluating and diagnosing the cases, especially the underdiagnosed cases. The learning outcomes from the today's webinar is properties of RBC, the normal morphology and its abnormal morphologies. A few points about erythropoiesis. This megakaryocyte erythroid progenitor is the basic progenitor cell from which RBCs develop. In the presence of erythropoietin, this cell develops into proerythroblast. This is the initial cell which has a basophilic cytoplasm, and the cytoplasm forms 1/5 of the cell. The nucleus is 4/5. It has a prominent nucleoli. This is a dividing cell. The next stage is the early erythroblast, where it has a basophilic cytoplasm and a condensed nucleus. It is also a dividing cell. It has a light pinkish cytoplasm. Coming to the intermediate erythroblast, it is intermediate because it is between the dividing stages and the non-dividing stages. And it has a polychromatic cytoplasm because of its hemoglobin content. Next is the late erythroblast, where the cytoplasm is pinkish purple because of the increased hemoglobin content, and the nucleus is very pycnotic. Next stage is a nuclear extrusion, where the nucleus is expelled out to form a reticulocyte. This is almost larger than the size of a normal RBC, but it doesn't have a nucleus. It is again the cytoplasm is polychromatic because of its ribosomal RNA content, which can be stained by supravital stains. This reticulocyte, on entering into the circulation, it matures into normal RBC within 1 to 2 days. Coming to the abnormalities, the first is a variation in the size. In this, we cover about variation in the hemoglobin content and the variation in the shape. First variation in size is microcytosis. Normally, the RBC is 7.2 to 8 micrometers in diameter. If the cell is less than 7 microns in diameter, we call it as microcyte cell or microcytosis. It is usually compared with the size of a nucleus of a small lymphocyte, which is 8 micrometers. This is a HND stain picture where we can see microcytes when compared with the size of a small lymphocyte. This condition is seen mostly in iron deficiency anemia commonly, which we come across in our day-to-day practice, thalassemia, sideroblastic anemia, lead poisoning, and anemia of chronic diseases. Coming to the next abnormality is macrocytosis. When the cell is larger than 9 micrometers in diameter, it is macrocyte. This macrocyte can be round or oval in shape, and depending on its diagnostic significance is different. If it is oval, it is seen mostly in iron and folate B12 deficiencies. If it is round, it is seen in ethanol, intoxication, liver disease, and reticulocytosis. And this is a pictograph where we can see macrocytes. Next is the variation in hemoglobin content. The first is hypochromasia. Normally, an RBC has 1/3 of the central pallor. If the central pallor is more than 1/3, it is hypochromasia. It is seen in conditions like iron deficiency, thalassemia, anemia of chronic disease, lead poisoning, hyperthyroidism, copper deficiency. Any condition leading to microcytosis will have hypochromasia. Next is a polychromasia. These red cells will have a bluish-gray shade of cytoplasm. It is mainly due to uptake of both the stains, eosin and the basic dyes. Eosin is by the hemoglobin and basic dyes is by the residual ribosomal RNA. These are usually round in shape. Conditions, this polychromasia seen is with reticulocytosis. They go hand in hand, mostly for excessive bleeding, hemolysis, or any response to hematostatic factor replacement. This is a picture where we can clearly differentiate polychromasia depending on the size and the color. Next is macrochromasia. There is a reduction in central pallor on the blood film, and it can be defined as increased red cell hemoglobin concentration. Causes are spirocytes. It is seen in hereditary spirocytosis, autoimmune hemolytic anemias, and Clostridium infection. Microspirocytosis is seen in microangiopathic hemolytic anemia and severe burns. Macrocytosis most commonly is seen in B12 and folate deficiency, chronic liver diseases, alcohol abuse, post-splenectomy, and myelodysplastic syndrome. Coming to variation in the red cell shape, which is also called poikilocytosis, the first condition is spirocytes. The cell's normal red blood cell is usually biconcave, but here the cells are more spherical. They don't have the central area of pallor. Most common condition is hereditary spirocytosis, but can also be seen in autoimmune hemolytic anemia, microangiopathic hemolytic anemia. And this is a picture how we have to differentiate between the normal RBC, the spirocyte, and the macrocyte. Both the normal and macrocytes have central pallor, where the spirocytes, they are a bit darker compared to the surrounding cells. This is a picture where we can see spirocytes. The black arrow indicates these are more spherical in shape and they're darker compared to the surrounding cells. Little bit of pathophysiology of hereditary spirocytosis. As we know, the red cell usually has a biphospholipid membrane, and internal to it is a cytoskeleton. The main property of cytoskeleton is spectrin. Any mutation in this spectrin may lead to the membrane loss, and there is a stability decrease. So due to this decreased stability, the surface to volume ratio will decrease. So the cells becomes more spherical and they get stagnated. They cannot pass through the small splenic capsule venules within the splenic blood vessels. So they get stasis, and later they will be phagocytosed by the splenic macrophages, resulting in extravascular hemolysis. I wanted to emphasize here the decreased surface to volume ratio is a main factor which plays an important role in osmotic fragility test, where the cell cannot accommodate more amount of water. Even in a mildly hypertonic solution, they get hemolyzed. So the osmotic fragility will be increased in case of hereditary spirocytosis. Similarly, spirocytes not only seen in hereditary spirocytosis, it also seen in immune hemolytic anemia and microangiopathic hemolytic anemia. So these three can be differentiated using a direct Coombs test, which is negative in hereditary spirocytosis. The next annex of poikilocytosis is target cell, which is also called codocytes or bell-shaped. These target cells have a more surface area than its volume. The envelope is too large, and they have a less oxygen concentration when compared to the normal RBC cells. This is how a target cell look. They have a central dark region in the central pallor area, also called as a bullseye appearance. It is seen in conditions like thalassemia, severe iron deficiency, obstructive liver disease, post-splenectomy, and hemoglobinopathies. This is a HNE stain picture of a cirrhotic patient where we can see many target cells. And this target cell is formed because when we spread the cells on a flat glass slide, the top part of the bell shape gets pressed into the central part, giving the target cells. This target cells may be an indication for underdiagnosed thalassemic patients, which is a cause of chronic anemia, or it might be fatal in conditions. So recently, the government of Gujarat has passed a bill for the mandatory screening of thalassemia for all the married couples. Ovelocytes. The next is ovelocyte. These cells are oval in shape, has a diameter more than 9 micrometers. Conditions, they are seen in hereditary ovelocytosis, even in sickle cell anemia, thalassemia major, and megaloblastic anemia. Next is elliptocytes. These cells are oval or elliptical in shape. The longer axis is twice to that of the short axis. Polarization of hemoglobin occurs at both the ends. It is seen in iron deficiency anemia, a condition called hereditary elliptocytosis, thalassemia, megaloblastic anemia, and myelophthisis anemia. This is a H&E stain picture of a 35 to 40 years female patient, which we came across in our Hapsibuda center. The peripheral smear has multiple hereditary spherocytosis, and this is a high power view. The patient is on hydroxyurea. Initially, the platelet count is 20 lakhs. Now it is 8 lakhs. Further follow-up of this patient is being done. Next is a teardrop cell. These red cells shaped like a teardrop. They have elongated or pointed proximity. This is due to a membrane damage. These teardrop cells are seen in bone marrow fibrosis, megaloblastic anemia, iron deficiency anemia, sickle cell and myelopathisis anemia. The reason behind it is when the bone marrow is increased with connective tissue, or when the bone marrow is infiltrated with the tumor cells or leukemia cells or any metastatic cells, the RBCs, when they try to come out, they get squeezed and they produce a teardrop cell. Even this, it happens with the spleen when it gets infiltrated by any connective tissue. This is how a teardrop cell appears with a pointed extremity. The next cell is a blister cell, also called as Spherostomatocyte. It have an eccentric halo area. It is mostly seen in microangiopathic hemolytic anemia. This is a cell picked by the splenic mechanism. Next is the cystocytes, fragmentation of red cells. These cells show a half disc shape with 2 or 3 pointed extremities. And the main differential diagnosis for the cell is when we see under a microscope, any degenerated cell can appear as a cystocyte. So it is important to differentiate between a degenerated cell and a proper cystocyte. It is seen mostly in microangiopathic hemolytic anemia, mechanical hemolytic anemia, burns, hereditary pyropolycytosis, thalassemia, and even in carcinomatosis. Next cell is a stomatocyte. These cells have a central linear slit or a stoma. It has a mouth-shaped form in a peripheral smear. It is also called as a cup cell or a mushroom cell or even a uniconcave disc shell. It is seen in conditions like chronic liver disease, cirrhosis, hereditary stomatocytosis, hereditary spherocytosis, and erythrocyte sodium pump defect. It is graded as 3 grades. First grade will have a small shallow dip. Intermediate is the second, and the small dimple is the third grade. BURR cells, also called as crenated cell or echinocytes. These cells, RBCs with a uniformly spaced pointed projections on their entire surface, we call them as BURR cell. And the main mechanism is due to the abnormal lipid composition of the cellular membrane. Mainly the outer leaflet of the membrane is involved. Conditions involved is seen in uremia, liver diseases, low potassium red cells, also in immediate post-transfusion cases with metabolically depleted cells or in carcinoma of the stomach. Similarly, the differential diagnosis is improperly prepared smear or aged blood, and any pH alteration of the glass slide may produce a BURR cell. These are the BURR cells, which are uniformly spaced projections. And there are 4 grades of BURR cell. Grade 1 is very small, short projections, to grade 4, very prominent projections. This is a small model of how an echinocyte is produced. The RBCs with the outer leaflet abnormality results in echinocytes, whereas the inner leaflet may produce stomatocytes. Next cell is a keratocyte. It's also called as a horn or a bite cell or a helmet cell. These are the RBCs with spicules resulting from ruptured vacuoles. Part of the cell fuses back, leaving 2 or 3 horn-like projections. This keratocyte is a fragile cell and it remains in circulation for only a few hours. It is said that whenever a hinge body is removed from a cell by the spleen, it produces a bite cell or a keratocyte. Conditions seen are DIC, severe burns, and EDTA artifact. Acanthocytes. Acanthocytes or spur cells or spike cells. These are the cells with irregularly spaced projections on this surface. These projections are of different length and width and even position. These cells are most commonly seen in liver diseases, post-splenectomy, A-beta lipoproteinemia, anorexia nervosa, and starvation. This is how a thorn cell looks with irregular projections and irregularly spaced. Next cell is a leptocyte, which is usually very thin red cell, also called as a wafer cell. There is a thin flat hemoglobin at the periphery. These cells are seen in thalassemia and obstructive liver disease. Coming to sickle cells, which are also called drepanocytes, these are sickle-shaped cells. We call them as sickle cells, and there is a hemoglobin polymerization, abnormal hemoglobin polymerization, which leads to fluid polymers, and these polymers gets accumulated, and they disrupt the normal biconcave cell to form a sickle-shaped cell. And these sickle-shaped cells, they cannot pass through all the capillaries, and they get stuck, resulting in obstruction to the blood flow, which may finally leads to pain crisis or hemolysis. These are seen in sickle cell disorders, either in homozygous or in triad, or in combinations with thalassemia or hemoglobin C. This is how a sickle cell formed. There are various types of sickle cells. Initial classic cell will be like this. Later, both cell. There is an envelope cell, envelope shaped, oat cell, a rhomboid shaped cell, demi-lune cell, microspherocyte, target cell, cell with Hall gel bodies and RBC fragments. This is how a sickle cell will progress. Sickle cells will be diagnosed gold standard by method like HPLC, high performance liquid chromatography and SICKLE test. It shows a peak near the S window. Coming to erythrocyte inclusion bodies, there are different types of inclusion bodies which can be stained either by the Wright's-Giemsa stain method or by iron stains or by intravital stains like hinge bodies and HBH inclusions. Before reporting as inclusion bodies, we have to distinguish them from stain particles, overlying platelets on the RBCs, or dirt on the slide, or any bubbles. All these inclusions usually represent the nuclear or the cytoplasmic remnants. Coming to the first inclusion is a HOWELL-JOLLY body. These are small and spherical with dark purple cytoplasmic inclusion. They are usually located eccentrically and seen singly. These are seen in post-splenectomy cases, any functional hyposplenia, megaloblastic anemia, and severe hemolytic anemia. The important differential diagnosis is platelet overlying red cell. It shouldn't be confused with platelets, Pappenheimer bodies, and any artifact. Why these Hall gel bodies are formed? These are mainly due to the abnormal mitosis where a single chromosome fails to participate in the interphase. So that mitotic spindle will and they remain behind, and the rest of the nucleus is extruded out. Next is the siderotic granules or Pappenheimer bodies. These RBCs contains hemoglobin iron granules. They are purple in color, irregular granules less than 1 micrometer in diameter. They are also located peripherally like Hall-Jelly bodies and unevenly distributed. But the differentiating point is they appear in pairs, tetrads, or in tight clusters. These are seen in hemolytic anemia infections, post-splenectomy, sideroblastic anemia, thalassemia, and congenital dyserythropoietic anemia. Coming to the third one, basophilic stippling. They are multiple and uniformly distributed cells. They can be either fine or coarse, dot-like things. Coarse one, they have a variable-sized basophilic granulation, discoloration across its entire cytoplasm. They suggest impaired hemoglobin synthesis. They are seen in thalassemia, heavy metal poisoning like lead, hemolytic anemia, megaloblastic anemia, and liver diseases. And the fine basophilic stipplings are also dot-like structures across the entire cytoplasm. They are associated with reticulocytosis and they do not have much of clinical significance. And these are the basophilic stippling RBCs, which are distributed across the entire cell surface. However, these inclusion bodies appears the same when we see on the peripheral smear. So this is a picture which helps us to remember in much detail. Nucleated RBCs, they have a pycnotic type of nucleus in the center or towards the periphery. These Hall gel bodies are very small, less than 1 micrometers, again in the periphery. Pappenheimer bodies are periphery and they are in tetrads, whereas coarse basophilic granules are distributed on the entire surface and they are multiple. Coming to hinge bodies, they represent the denatured hemoglobin within the cell. These usually take up the stain, supravital stain like brilliant crescel blue or methylene blue. And the presence of hinge body indicates the red cell injury and is associated mainly with G6PD deficiency. And these are the hinge bodies. This is on methylene blue staining, and this is a HND stain where we can see hinge bodies. The next is the CABOT ring. These inclusions appears as reddish blue thread-like structures like a ring form or a figure of 8 pattern. They usually again represent the remnants of microtubules of the mitotic spindle. However, they are very rare findings but can be seen in megaloblastic anemia, severe anemia, leukemia, lead poisoning, and other causes of any dyserythropoiesis. This is how a CABOT ring looks in a RBC peripheral smear. Coming to nucleated red cells, these red cells are released from the bone marrow early into the bloodstream when there is a need for oxygen, and these nucleated red cells represents a normoblast in the peripheral blood, typically at the orthochromatophilic stage. These cells appears as a darkly stained blue cells with a bluish, purple-bluish hinge of cytoplasm surrounding it. This is usually confused with a lymphocyte, and these nucleated red cells usually present more at birth and generally disappears within 3 to 5 days. These are seen in hemolytic anemia, marrow fibrosis, marrow infiltration by leukemia or lymphoma, or metastatic tumors. Corrected WBC has to be done, which is obtained by the formula obtain WBC into multiplied by 100 upon normal NRBCs plus 100. These are usually counted as lymphocytes by automated analyzer. Next is reticulocyte. These are again the immature RBCs which are released into the circulation. They contain polychromatic ribosomal RNA, which can be demonstrated by supravital stains. Normal value of retic is 0.5 to 2%, and in cord blood 1 to 7%. Depending on the days and the months, the retic count varies. These are increased in hemolytic anemia or following therapy in nutritional deficiencies. This retic count decreased in aplastic anemia, pure red cell aplasia, Fanconi's anemia, aplastic crisis in sickle cell anemia, and hereditary spherocytosis. Coming to next, red cell agglutination, where there is an irregular clumping of red cell. The single RBC cannot be differentiated. These are mostly seen in cold agglutinins or warm autoimmune hemolysis. Further evaluation of the test is needed using direct Coombs test. Next is a Rolex formation, where the RBCs usually piled up like a stack of coins. These are mostly seen in hyperfibrinogenemia or hyperglobulinemia, or like plasma proteins. In these patients, when the protein content is more, the peripheral blood smear appears bluish background because of the increased protein content. These are my references. Thank you. And this is an initiative taken up by the Gujarat government for the mandatory testing of the couples for thalassemia. With this, I end my talk. Thank you.
Thank you, Dr. Gayatri, for a very extensive presentation on this very important topic. The session is open for questions. Kindly type the questions in the question box. I have one question, which is asked by Priyanka. The question is, if in the peripheral smear study, if we find 1 to 2 sickle cells, how do we go about it?
Yes, ma'am. Even 1 to 2 sickle cells indicates that it can be a sickle cell trait or a homozygous sickle cell. So we have to confirm using a gold standard methods like sickling test or HPLC, and further screening is also needed for all the family members along with genetic counseling and all. It is significant, but not be a diagnostic indication.
Thank you. How about the interference of cystocytes in cell counter? This is another question in the question box.
Spirocytes on a
Cystocyte.
Cystocytes, okay, ma'am. These usually indicates a fragmented RBCs, can be a microangiopathic hemolytic anemia, and another significance is it can be a false negative result also. So further microscopic evaluation is needed, which can be ruled out by seeing it either as macrocytosis or it is a false negative case.
Any further questions? I see no more questions. Thank you all.
Thank you, ma'am.